right. Well, I want to welcome everybody to on this beautiful Friday afternoon here in Baltimore. I hope it's as lovely where you all are. Welcome to today's panel, Tailored Plan Design for Underserved Populations of Medicare Advantage. This is the second webinar in our monthly series, Conversations on the Business of Health. This series is hosted by the Hopkins Business of Health Initiative, or HBHI. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. We focus on the role of business and incentives in advancing an affordable and equitable high-value health system. And so it's just wonderful to have today's panel, which ties nicely to our overall objectives here. So I'm going to turn the proceedings over to our moderator and HBHI expert on today's topic, Andrew Anderson. He's an assistant professor in the Department of Health Policy and Management at the Bloomberg School of Public Health here at Johns Hopkins University. And take it away, Andrew.
Thanks, Dan. Welcome, everyone. So today we're going to get right into it. I'm going to start by introducing our exceptional panel. First I'll just say we're here to discuss, the rise of tailored Medicare Advantage plans. We have three panelists. The first is Andy Higgins, who's Vice President of Product Development at Cleaver Care Health Plan and leads efforts of the MA plan that blends traditions of Eastern medicine and Western innovations, and it offers culturally responsive healthcare options that meet the needs of underserved groups. We also have Sachin Jain, who is the CEO of SCAN Group and SCAN Health Plan, one of the largest not-for-profit Medicare Advantage plans in the country. Under his leadership, SCAN serves more than 300,000 members across several states. We also have Casey Swartz, Senior Counsel for Education and Federal Policy at the Medicare Rights Center. Casey has been instrumental in shaping federal policy and ensuring that Medicare beneficiaries and the professionals who support them have access to accurate, actionable information about their coverage. Before we dive into today's discussion, I'd like to introduce Mark Meiselbach, who is a health economist and assistant professor in the Bloomberg School of Public Health. Mark's research focuses on understanding the policy and market conditions that shape insurer offerings in privately managed insurance markets, including employer-sponsored insurance, Medicare Advantage, and Medicaid managed care. All right, take it away, Mark, and then we'll come back to the panel.
Great. Well, thank you for the opportunity to present a brief
Mark,
research.
you have your speaker slides on.
Sorry. Okay, let me share my second screen. Apologies. Can you see the right view? Thank you. Well, thank you for the opportunity to present a brief research update, and I'll end on a discussion of future topics within this area, since I think this is really an emerging area for health policy research. As Andrew mentioned, I'm an assistant professor and a health economist in the Johns Hopkins Bloomberg School of Public Health. So I think we'll hear a lot from our panelists today about why these plans are being offered. But I think from a researcher's perspective, it's fairly clear. As many people in attendance probably know, Medicare Advantage enrolls over half of Medicare beneficiaries at this point, and a disproportionate share of those enrollees are racial and ethnic minorities. So you could see, for example, that over 60% of Hispanic Medicare beneficiaries are enrolled in the Medicare Advantage program, over half of Black Medicare beneficiaries, and just around 40% among white Medicare beneficiaries. So despite the disproportionate enrollment in Medicare Advantage, so far there's somewhat limited evidence that Medicare Advantage plans have really mitigated disparities in access or outcomes. So naturally, there's been sort of a growing number of plans offering tailored plan design, something we're referring to as MA affinity plans in the literature, that are being marketed to meet the unique healthcare needs of underserved populations. I think a somewhat sunny view of this is that the goal of this could be to reduce health disparities by tailoring solutions based off of the specific needs of underserved populations. A more cynical view perhaps could be that this is a great potential new way to market a plan in a increasingly competitive Medicare Advantage landscape. Our initial research objective was fairly simple. We wanted to start by identifying a list of tailored plans so that we could describe trends in enrollment, assess plan characteristics, and also aid future researchers who want to study this emerging topic. So our search process, which involved multiple reviewers, identified 61 total Medicare Advantage affinity plans in 2024, enrolling just under 50,000 enrollees. So, total enrollment, at least in the categories that we've identified here, is still fairly limited, but rapidly growing and doubling year over year. By far, the largest target population we identified was plans targeted towards Asian American beneficiaries in particular. This is all part of a forthcoming publication at the Journal of General Internal Medicine. And as part of that publication, we'll also be publishing the full list of the identified plans with the goal that others can critique and add to this identified list and hopefully create more of a research community around this topic. So we briefly summarize as well the characteristics of these plans. We saw that the vast majority were health maintenance organization plans. Unsurprisingly, they were associated with fairly new contracts. So more than half were associated with Medicare Advantage contracts started in 2020 or later. And perhaps because many of these plans are new, a larger share of them did not have adequate data or were too new to be rated by the CMS plan quality star rating system. But among those that were, on average, we did see that the CMS plan quality ratings were somewhat lower for these plans than other plans in Medicare Advantage. And our panelists may have some thoughts on why that might be and what challenges that represents. I think there are sort of a countless number of future directions for research in this area. But things that we've identified for future research by our team is to understand first how plans are tailoring their benefits. So you could imagine supplemental benefits are being used to meet the specific needs of underserved populations. You could imagine provider networks are being designed with the idea of racial and language concordance in the types of providers that are in networks meant to serve certain populations. But ultimately, we want to understand the impact to enrollees. We want to know how the methods that these plans are using and this tailored plan design is affecting access to care for underserved populations, patient experience, and ultimately their health as well. So I'm very excited to hear the other panelists' thoughts on these questions, but I'm also hoping that the discussion today will lead to many future questions. So I, like hopefully all of you, am very excited to hear from our other panelists. So thank you very much.
Thanks, Mark. And also feel free to drop questions in the chat along the way, and we have an open Q&A here. So to kick off the conversation, I wanted to pass it over to Sachin just to talk a little bit about how you see what the motivation is for plans, insurers creating these types of plans, and sort of how this strategy aligns with broader goals such as growth and equity.
Yeah, no, thanks so much for the opportunity and great presentation, Mark. The motivation at a very high level for a plan to do this kind of work is growth. This is a very, very competitive marketplace. There are 70 plus plan offerings in LA County right now, and everyone's looking for some opportunity to create distinction, differentiation, and an edge. And so I think what you're seeing is a natural evolution of a competitive marketplace, which is that plans are increasingly trying to differentiate themselves to stand out and attract, segments of the consumer population that have historically been ignored. I want to, echo Mark's comment that I think that we're really in the kind of the first inning of this journey. But I would be, loath to not acknowledge that there have been a number of kind of startup plans preceding the ones that are represented on this panel that actually disproportionately focus on these populations. They were oftentimes led by ethnic physicians who recognized that the populations that they served were ignored by traditional health plans. And only recently has kind of the venture and, kind of national plan community recognized that, the specific tailored plans could be good for business. Now, because we're in the first inning of it, I think, some of the execution has been really good, and some of it's been really shallow. Shallow looks like, websites that are translated, kind of using, outside vendors to, mimic the language of the beneficiaries that you're targeting. And then excellent looks like, plans that are actually contracting with specific provider networks, thinking differently about their benefits, thinking differently about the overall messaging. And you have to remember that there are segments of the older adult population that have historically been ignored by the healthcare system. And so some of what we're doing here is helping people to be seen. Scan, a couple of years ago, launched our LGBTQ plus product, Scan Affirm, thinking we might enroll a couple of hundred members. And today we have over 1,000 members in that product, in part because we're offering tailored benefit design, but in part, it's because our message is really resonating with, a community that's not necessarily represented. We compete nicely with Andy's plan, Clever, in this market, and they've done some amazing work to build, networks of acupuncture providers, and they provide really generous herbs and supplemental benefits that, frankly, are ignored. That a traditional plan actually has no really even sense that that's valuable to the population. So I think that these plans have a ton of potential, but I want to really just underscore the point that we're in the first inning of this. And also, I would be loath to not mention the comparison between, MA and traditional Medicare, because that's the bigger debate that's brewing. Certainly appreciate this conversation, but nothing like this is happening in traditional Medicare. And I think it's just important to say that out loud. Nobody is tailoring anything for any particular populations in traditional Medicare. So I think that this presents a real opportunity and access for innovation.
No, thank you for that. I'm curious if you have any thoughts about this as well, Andy, given the work that you're doing at Clever.
Yeah, absolutely. I appreciate the opportunity to be here too. I think Clever Care is one of those. When we looked at those bars a minute ago that Mark presented, we're one of those bars. We're part of that bar. Founded in 2020, new plan founded by 3 Asian Americans who had parents who were Medicare eligible, and just kind of had a recognition that like the MA plans that were out there weren't quite meeting their needs. And some of the stuff that we think about, and I think the benefits are like the tip of the iceberg, to use an overused analogy. The benefits are one thing, but anyone can slap some benefits on a plan, but it's really about the administration and doing it right underneath, and having the right service model, the right distribution model, working with the right vendors that are aligned with their cultural needs that really make this work. But the founders had a recognition that there were some things that were not, going well for their parents in that market. I'll just highlight a couple of them. So Sachin mentioned herbal supplements, so that's one piece of the puzzle. So, traditional OTC benefit, Band-Aids, aspirin, ACE bandages, the stuff that you can buy with your HSA card, that's pretty much what got offered. And we saw that benefit ramp up and up and up and up. The allowances in Medicare Advantage plans for OTC items get higher and higher. But, folks in our communities, our Korean American, Vietnamese American, Chinese American communities, a lot of that stuff, you could give them $500, but they may not be getting the things that they want. They may want red ginseng, they may want herbal teas, things that, in Eastern medicine are used, as sort of a first line of treatment by billions of people across the country or across the world. So we wanted to make those items available as well and make them part of our OTC benefit. It's kind of easy to say, hey, we cover herbal supplements, but it's a little bit harder to execute that and to make sure that the stores where these beneficiaries shop, the items that they use, at the places where they live, meeting where they're at, the administration of that's difficult. So, not only adding that benefit was important for Clever Care, but also making sure that the stores and the items that were really important to our members to help keep them healthy were in the product. One other example too is our fitness benefit. If you go back just a few years, there's a fairly standard and pretty good fitness benefit, kind of one size fits all, national network of gyms that most Medicare Advantage plans had. Only recently you've seen evolution of the fitness benefit to go kind of beyond that fairly standard off-the-shelf benefit. When we looked at our membership, we've got very healthy members that are very active, but a lot of them don't typically engage in the type of working out or fitness that we think about in the States. They're not going and putting on a weight belt and doing deadlifts. They might not be running on an elliptical machine, but they do other things like Tai Chi or traditional dance classes or even play golf. So building out a more robust fitness network and opening the aperture in terms of how we define fitness and wellness for this population, meeting them kind of where they're at and the activities that they engage in was important as well. So those are just, those are a couple examples that we got into. The last one I'll highlight is just acupuncture. That is a covered benefit for Medicare Advantage plans. But not only just ramping up the allowance, but making sure that we have a robust acupuncture network and the practitioners that are in the communities that we served are in the network. And we're also covering not just standard acupuncture treatments, but other types of treatments that those practitioners provide, like traditional massages, cupping, and other types of therapies that are covered in our plan as well.
Thank you for that. I might circle back on some of those examples in a moment, but I wanted to ask Casey, just a little bit about how you see these types of plans fitting into the broader Medicare landscape. Maybe some of the potential unintended consequences or benefits.
Yeah.
From your perspective.
Thank you so much for having me, and I think what has been said so far is exactly right, both in terms of the newness of officially marketed niche plans and also the long-standing existence of plans that fit into various niches in communities. I think that has existed. I think the expansion of supplemental benefits is inextricably tied to the creation of these products. I think that whereas a lot, I know Andy said that the benefits are the tip of the iceberg, but I think they are also a driver here. And I think that ignoring supplemental benefits as a driver of differentiation minimizes their impact. And I think that the area of supplemental benefits is one that, from the beneficiary advocacy and broader programmatic policy space, we have concerns about. There's a lot of promise in this space, as has been described here, but there's also, I think, as Sachin mentioned, there's a lot of attention on the comparison between original Medicare and Medicare Advantage currently. And I think one of the things that is a touch point or a strike point for that comparison is the amount of money that's being spent on supplemental benefits and whether those sums are reflective of or create perverse incentives with regard to overpayments or other problems in broader, and this is not specific to any of the plans here, but broader Medicare Advantage reimbursement rates as compared to the cost of insuring those same individuals through traditional Medicare. So I think that these benefits are hugely valuable to people. They're really interesting to people. They, I think our perspective on supplemental benefits is that there should be more transparency around them with regard to how they're being offered, who is getting them, not just what's listed on the websites, but how those supplemental benefits are actually being utilized by people in the plans. And I think, Andy, you mentioned this and you're exactly right. There's a massive difference between the benefit being available and then the benefit being utilized. And that gap can include both things like how easy it is to contact your plan to get information about how to use it, but also, are the stores in your neighborhood participating? Can you get the things that you would like to get with that additional benefit?
Actually,
I think the other sort of concern space is, and you mentioned this exactly, Andrew, how these plans and the specific affinities related match up with or intersect with, or maybe are confused with other benefits that may exist in Medicare or outside of Medicare, how affinity plans may rub up against the idea of lookalike plans for duals. So plans that target dual eligible enrollees, but do not meet the standards for special needs plans for dual eligibles. So plans that enroll a lot of duals, but don't meet standards for dual and for plans that in fact target duals. I think there's a real risk that affinity plans could be used to market a lookalike plan. And I think that we really want to be wary of growth in that space, because I think the increased standardization and increased restrictions / requirements for duals plans are hugely important for ensuring that care that's delivered is coordinated and well integrated between Medicare and Medicaid. And lookalike plans really undermine that.
Yeah, no, those are some really good points. Do either of you have any reactions to those potential sort of issues that she raised?
Yeah, look, go ahead, Andy. Go ahead.
All right, Sachin, thank you. So, I mean, I think the policies the winds are blowing in that direction to increase regulation, first of all, right? So, we know that plans are going to be required in 2025 to inform beneficiaries that aren't utilizing supplemental benefits that those benefits are going to be available mid-year, right? So there are policies now in place to ensure that we're telling people about those benefits to make sure they're utilized and we aren't sort of like sweeping them under the rug. The threshold for having dual eligible members in a product is going to continue to decline. So you can't have products, sort of general enrollment products that have mostly dual eligible members in them. That threshold will decline from 60 to 50%. It's going to continue to decline. So they're going to ensure, I think, policies and ensuring that we're not putting so many lookalike plans out there. So I think there are a lot of policy moving in that direction. But I think a lot of the concerns, Casey, I think, are founded and are things that we think about as a plan. But I think, and Sachin, I'm sure would echo this, but if as a plan, you're not doing the right thing by your member, you're not taking care of members, not ensuring good health outcomes, you're not ensuring satisfaction, they have a choice, right? So they are going to choose somebody else in the long run. So plans that are not doing it the right way over time and meeting the needs of their members in these unique populations are not going to be successful long term.
Sachin, do you want to jump in?
No, I agree with everything that Andy said. I mean, look, I'm trying to not pull us into the broader MA versus traditional Medicare conversation and try to stay focused on the topic at hand. But there's a lot of challenges to actually effectively executing on an affinity plan as well. And I don't want to speak for Andy, but as a keen observer of the market, when you disproportionately select a particular kind of population, you're going to disproportionately have some benefits of serving that particular population, but also some challenges. So turns out Asian Americans are, and we just launched full disclosure, we just launched our own Asian American focused health plan, in the LA, Orange County, and San Bernardino and Northern California markets. The medical loss ratios of serving that population, because they don't typically like to seek traditional medical care through emergency room specialists, primary care doctors, are actually relatively low. And not to kind of, play into racial or ethnic stereotypes, they're also very hard graders. And they end up actually, scoring their plans a lot lower. And if you're actually launching a plan that's focused on that population, the cap scores of these plans tend to be a lot lower, because the norms around how you rate plans tend to be lower. Now, it could be that the plans are also, just not as good or whatever it is, but it, and it's hard to really tease all of that out. But at the same time, there are specific nuances that CMS never contemplated when they built the regulatory infrastructure for plans. And again, I think it speaks to a broader need for CMS to reimagine itself, to be really candid with you. CMS still is kind of built on a fee-for-service chassis, still imagines itself as regulating primarily a fee-for-service program. And then there's this MA thing on the side. Turns out 51% of beneficiaries are now in MA. And so, we have to change how we do base payments, change how we do star ratings, change how we do risk adjustment. There's a lot of noise in the system about how all of these things are done. But the reality is, if you had to give CMS a grade for how it's regulated this program, and Congress, I should say, because it's all intertwined, it's been through these like waves of regulation, as opposed to a continuous tweaking of the program. And I think because of that, it's actually introduced a lot of instability to the program, and like waves of instability. So you see, like this last 3 years, you've seen changes in the risk adjustment model, changes in the base rates, and you've also seen changes in how star ratings are calculated, which from a beneficiary impact, it's all good. It's, these are all changes that needed to happen. But when you do them all at once, you see the massive cataclysm of change for the beneficiaries, which is plans are exiting counties, plans are slashing benefits. And so again, I think that there's a lot of work to do to make sure that these targeted plans are doing what they are intended to do, as opposed to just being kind of fancy, marketing and gimmickry that doesn't necessarily serve people particularly well.
Don't forget the Part D benefit.
So forgot about that. Sorry,
just
Andy.
A massive amount of things we're reacting to.
Yeah. Good point. This totally is, I mean, I will say we're a small shop, so the fact that this conversation is happening during open enrollment is like several people are like, oh, okay, so a whole afternoon where you're not, yeah. So I appreciate the upheaval. I will say that maybe two small things in response to what you guys just mentioned. The first is, you said if you're not doing a good job, people will vote with their feet and leave your plan. And I think that is more true in some markets than others. But I think the other, both in terms of the number of plan options and in terms of sort of I think there are also cultural and network, provider retention reasons that people both mid-year, when something sort of not what they want to be happening is happening, but also on an annual basis, don't really do the type of shopping that the premise of the market is built on. I think
Casey, can I ask you a question? I mean, you represent beneficiaries. You're thinking a lot about beneficiary rights. A few years ago, I introduced the idea that, we should be thinking outside of annual enrollment, that actually annual enrollment is a distraction, that actually plans are not able to really focus on beneficiary health when they're focused on in-year retention and like product tweaks to kind of keep people in plan. What would your reaction be to like a 3 or 5 year enrollment cycle in a plan that actually enabled greater investments in upfront chronic disease management, outpatient ambulatory intensive management of serious, conditions? What's your take on that?
What's my take? So I wear two hats predominantly. Yeah. One is the policy work that I do that involves like thinking about Medicare as a concept and thinking about how we want plans and the program to operate across the millions of people enrolled. And then the other thing that I do is work with individuals who are calling our helpline because they are having a problem. And we oversample for complaints. Obviously, people aren't calling because things are going great. But the ability, and this is actually the sort of the second thing, the second half of what I was saying about competition, is that in a market, in a space where there isn't robust Medigap rights, and where a person doesn't have Medicaid and isn't very independently wealthy, MA is the only way that they can protect against potentially catastrophic out-of-pocket costs. And whereas Medicare, when MA was introduced, traditional Medicare was at least theoretically affordable in terms of cost sharing without supplemental insurance. In even the 90s and 2000s, it is just not anymore. And so for there to be real competition and this is again to the concept of MA versus traditional Medicare or MA versus fee-for-service, for there to be real competition to the concept of managed care in the Medicare space, there needs to be either an out-of-pocket cap on costs in traditional Medicare or really robust Medigap reforms that allow for much more open and free Medigap enrollment. And so I think that ability to move when things aren't going well is so important, that lacking that, locking people into plan choice for longer periods of time, it makes me very nervous.
Sure.
With a robust option, I think that looking at longer time horizons for plan responsibility, for plan assessments, for quality ratings, for outcome measures, I think longer time horizons for all of those things make total sense. I think that without the sort of escape valve for beneficiaries who are enrolled in a plan that suits their needs very well when they are healthy, and then find that either network or coverage restrictions are untenable when they become ill.
Well, look, I mean, Casey, the truth is that many consumers, unfortunately, don't even know what they're buying when they buy it. I mean, they think they're buying a Part B rebate, or they think they're buying a supplemental benefit. They don't even realize they're buying into a narrow network. And so there's a lot of,
Yes.
From my perspective, the real reform needs to take place at the broker level. I don't know that we actually have, and this is on no one's radar in the health policy community. I think this is it's actually
a lot of talk about broker reforms.
No offense, yes. Andrew and Mark, but your community has kind of completely missed the boat on this. The reform opportunity is really on the broker side, because the brokers drive a lot of the behaviors that are actually the ones that, frankly, are damaging to beneficiaries. And again, I think there's amazing brokers out there who do the right thing for the beneficiaries year in, year out. But there's plenty of people who are just selling people into the plan that gives them the greatest commission and broker override. And all plans look the same until you actually need them, to Casey's point, at which point, you realize who's going to pay your claim and who's not, and who's going to, make sure you get your care when you need it. So.
Yeah, I totally agree with that too. And, there are incentives for brokers to just kind of set it and forget it for their client base, right? So, and you think about folks in this age group, in this health status, they're constantly evolving. Their healthcare needs are changing. And you think every year there are probably more plans being offered, as we see. Their needs are being changed. So yeah, I totally agree with Sachin on this one. Like, there are a lot of incentives for brokers that may not be aligned with the patient needs, and there are probably a lot we could be doing there.
And I think whenever we're talking about brokers, I think we also have to talk about the public option for brokers, which is the SHIP network, which is just massively and chronically underfunded, especially as compared to the Navigator program. I think you see that pretty directly. The Navigators, people who are choosing plans in exchanges, in the state exchanges, often go to Navigators, know about Navigators, can find Navigators. People end up talking to brokers, and unscrupulous brokers because they don't know about ships, because ships are not advertising, because their ships are run by volunteers and under-resourced and under-supported. And they're a tremendous resource for people to find the types of plans that might really suit their needs, and plans that are targeted to their unique situation without the incentives that can drive plan selection through a broker.
Yeah. So both of you now, all three of you, you've brought up the needs of the very, consumers, members. How do you go about identifying the needs of those who you're trying to enroll in affinity plans? And to what extent have you all measured the impact that it's had amongst the various members? I think, Sachin, you had mentioned member experience and CAP surveys, but what's been your experience in the identification of needs and measuring impact?
Yeah, I mean, I think on the identifying of needs, it turns out there's a couple of different channels. One is actually working with the provider community that actually serves this population. So, we partner very closely with medical groups that serve particular populations, and then we'll ask them, what are the benefits that are going to resonate? What are the drugs that are most important? What are the supplemental benefits that are going to be most important? And oftentimes the feedback we'll get is actually what's most important is your network. It's not just that you have the Asian physicians in place, but you also need to have the pharmacies, and you need to have the ancillary service providers who are able to provide these services in language. So I think it's a lot of consultation with the clinician community that can then really point out. The other piece that we use is actually our employee base. We have an incredibly diverse employee base, and I think it actually speaks to the need for more diversity in our in your employee population. SCAN has really pushed on employee diversity over the last 4 or 5 years, and because we now have people who represent different communities, local communities, they're telling us what actually is needed in their communities. So I think it's really important. So. I mean, the last thing I'll say, sorry, the last thing I'll say is we actually employ a number of our own members as what we call peer advocates. And so we have a diverse group of those peer advocates. And so we'll also engage those folks in our product planning to better understand, what it is that our beneficiaries actually want.
And just
I think Andrew, similar to what Sachin said about providers and members and employees too. Clever Care, highly diverse, and we rely on our employee base. We also have community centers, in the communities that we serve. So locations where folks can come to music classes, fitness classes, they can ask questions. So we have staff there, that speak the language, that are constantly talking to members. I spent the last week out there last week. And those are really, the folks that work at those community centers and the members that are there are a really great source of information for us, boots on the ground that are literally in the communities to help us understand what's working and what's not working for them.
Got it. So it sounds like it's a continuous information gathering and then feeding it back into the decisions that you're making about the benefits, and as well as the I'm a little curious about the even Sachin's comment about the networks and the importance of networks, and how you think about how the preferences around networks are different for these groups versus maybe some of the other.
Sure.
Yeah.
I mean, there are definitely in California we have IPAs, physician associations, independent physician associates, and there are definitely some that are focused on certain languages and ethnicities. So you have to be aligned with the ones that align with your community. But Medicare Advantage plan is kind of a combination of stuff you use and stuff you don't use, but you might need. So I think Sachin's point earlier about not just the doctors they go to today, but providing insurance that if you had more serious illness or a medical event, that the facilities, that they know are kind of world-class in their communities are also available as well.
Yeah, the one thing I'll just say about the supplemental benefits, and this is the dirty little secret of it, and I want to say this out loud because I don't think we would be authentic if we didn't. is that the way we're able to offer these benefits is there's low utilization rates. If everyone was getting post-hospital meals every time, if everyone was using our transportation benefits, if everyone was using, one plan has a pesticide benefit, we wouldn't be able to offer it. And the way these things are priced is on a PMPM basis. The favorite one that I'll talk about is the virtual care benefit that I inherited when I first got to this to SCAN, which was unlimited virtual care for all beneficiaries, and it was priced at 99 cents per member per month. So for $12 a year, we were providing, unlimited virtual care to 300,000, $12 per member per year. We were providing unlimited virtual care to all members in our plan. Now, when we actually did the math on the utilization versus what we were paying for it, these were the most expensive visits that were happening in all of SCAN, because a handful of our members were actually using these visits, and we were paying $12 times 300,000 beneficiaries. So, again, I think that the scrutiny that's being applied to supplemental benefits is actually really well deserved, because I think there's been a lot of goodies that are offered to people, and frankly, some of those goodies are put behind glass, and they're very hard to access. So I joke about the pesticide benefit that's actually offered by one of the national plans. I learned, a year or two into that benefit being offered, that they actually literally required a doctor's note to get extermination services at your home. How many people use that? Just a handful. So, again, I think we have to be very, as we debate these programs and as we examine them, we have to just kind of talk about what's actually happening. And I just want to make sure I'm representing the plan community authentically and saying what's actually happening. So.
Yeah. I have two sort of follow-ups to that any one of you can answer. And so there's a broader question about the utilization of supplemental benefits more broadly, and not having a lot of visibility into that. But also, just related to the impact of the additional services or tailored services or benefits that you're offering to beneficiaries, maybe through supplemental benefits. What does the uptake look like among these, among the groups that you're collecting information from, and then, using that information to then come up with these customized strategies?
Yeah, I mean, I'd say I've worked on markets in the East Coast and Mid-Atlantic. I've worked in markets now in Southern California, and I would say there is an incredible discrepancy in the utilization rates of the same stuff amongst folks. So I think the level of awareness can vary greatly. So that can be kind of all over the map. I mean, Sachin's point about some of this stuff being, I'll call it window dressing to some degree, right? Stuff that has so much barrier, but you can throw it on a marketing piece. I think that absolutely has to be looked at. But at the same time, too, I think there's stuff that we do have evidence is going to improve health outcomes for folks, and we know it's only going to be applicable to a smaller population. So I think there's some philosophical questions about, do you put that stuff on a plan that may not affect everyone but could benefit a small number, right? But yeah, I've seen it. And a last thing I'd say here is I think we've struggled a bit, and I've struggled to tie concrete clinical evidence that these supplemental benefits are really driving better outcomes, right? So there are definitely studies, there's anecdotal evidence, but I don't know if anyone has really cracked
look, yeah, but Andy, I think we're also holding ourselves to too high an evidence bar, because I think on a population health basis, we're not going to move outcomes. I mean, I'm just going to say that out loud.
Yeah,
you give 12 people meals, you're not going to move public health outcomes. But for those 12 people, it actually makes a big difference.
It's a big deal,
right?
That's right.
So getting a few senior citizens off the road who shouldn't be driving by giving them a transportation benefit, amazing outcome for those folks, right? So I think in this situation, even though if it's a small n issue, for the small number of people who are impacting with these benefits, they're remarkable. I just think we have to be really realistic about what it is that we're doing. We're not exterminating 290,000 people's homes, which is a public perception, right? If you're actually requiring physician to do that.
Yeah.
Perfect. And
well, can I just also say, I think this is one of the times, and this is one of the areas that I think putting my my not individual client services hat on, but the broader thinking about the program as a whole. Because I think you're exactly right, Sachin. Those benefits for the people who can and do use them are extremely valuable, and especially when they are matched at the right time with the right need, they can be truly life-changing and health-changing. I think that from the perspective of Medicare and maybe Congress and maybe taxpayers, the fact that information about supplemental benefits is proprietary, is that details about their utilization, their impacts, their effectiveness are not being reported in a way to CMS that allows for public study and public scrutiny is a huge problem.
They should be part of star ratings. I mean, the truth is half the stuff in star ratings is garbage, right?
As reportable as anything else. And also beneficial, like we don't know how many people tried to get a benefit. Like, I think you're right. Some benefits only apply to certain people, but we also have no idea how many people tried to get a benefit and were rejected or refused that benefit. There's no appeals process for supplemental benefits. There's no tracking. There's no official denial required. The denials
there's an appeals. I mean, I want to correct the record on that. There is an appeals and grievances rate, and you know, there's a lot of those grievances. The grievances are disproportionately related to supplemental benefits. It's dental, it's transportation, and so if you look at a plan's reported, grievance rate, which is. Go ahead. Yeah.
Yeah. No, I appreciate that it goes into appeals and grievances, but it does not go into the appeals process that generates external review and does not have the standards. Though this is changing. I appreciate the publication of the standards for accessing those benefits will need to be made more publicly or made more available to members and their providers who are ordering them. But I think there's just like a very, in terms of that individual appeal, like someone will be able to see like, this is how you haven't met the standard. But that's still not something that we can review or have, people at institutions take on in terms of investigating and reviewing, because that information on a nationwide basis is just nowhere.
Mm-hmm. Yeah.
And I feel like it's a real problem in terms of, are these valuable things for the Medicare program, but also part of, if you go back and look at the regs that that changed the definition of supplemental benefit to expand for more non-health benefits, part of the rationale in that regulatory change was that MA plans can serve as incubators. And this goes to your point about what is being offered or what's being targeted in traditional Medicare. And this idea that really valuable supplemental benefits perhaps should not be supplemental. They should be brought into the standard benefit. They should be brought into the benefit for traditional Medicare, and it should be a required benefit for all MA plans. And without the both reporting to CMS and public release of that information, we can't evaluate that, and that purpose of supplemental benefits is being lost.
Yeah. One thing. So just in I just wanted to encourage folks to participate in the Q&A in the chat. So go in our final 10 minutes, please submit questions. And then I also wanted to just take the time to redirect the conversation a little bit too, if you could include in your next remarks, just where you see sort of the future of this going, maybe even related to some of the implementation challenges that you talked about, or some of you referenced earlier. How do you plan to maybe overcome those, or how have you, and just where do you see this going?
Yeah, I mean, I'll take the Clever Care membership, which not only are the vast majority of our members are not just English as a second language, but they're not English proficient. And when you think about an MA plan, it consists of a lot of vended solutions. A lot of the interactions our patients are going to have, our members are going to have, are with, with other vendors. And if a lot of the vendors that are providing, let's say, dental or transportation or any other vision benefits, they're typically doing that nationwide. So we have to be aligned with vendors who can meet our capabilities. And at the most basic level, it's the language capabilities, but a lot of times they have call centers, a lot of times they have digital assets, all their member touch points throughout the journey. We really have to interrogate each member touch point to ensure that someone who doesn't speak English proficiently, can do okay, and make sure that they're aligned. And what we found is that not every vendor is going to work for Clever Care because of those needs. And we need to be really deliberate about the vendors we engage with and ensure upfront that they're going to be able to meet the needs of our members.
Any thoughts, Sachin, on the kind of where you see SCAN in particular kind of continuing to invest in this in tailored plans, or maybe a
Look,
broader...
we've got three right now. So we have our LGBTQ plus plan, which grew far more than anyone imagined, which we're super excited about. The one thing I want to say about tailored plans is they oftentimes attract people who are not from the community that you're trying to attract. So it turns out we have an LGBTQ plus plan, but there's been aspects of that plan that appeal to other people who are enrolling in it, sometimes knowing, sometimes not knowing. We also have the industry's first women's product. It's kind of weird to be saying that in 2024, but last year we launched the industry's first women's product, which I think has actually not grown as much as we'd like it to, because women actually disproportionately are the shoppers and decision makers on these kinds of plans, and oftentimes are driving other decisions. We're continuing to make tweaks to that plan to drive some more specificity and make that more attractive. And then we launched our allied product, I think, which is our Asian product. The thing I will say is, and I think is worth some additional conversation, is the Part B premium rebates end up being a big part of a lot of these plans, and nobody talks that much about them. I think they get a bad rap. But I've been recently kind of changing my thinking on them, which is, just for everyone's benefit, these are plans, the plans that are advertised very heavily on TV. You could be getting $100 a month back from your Medicare plan, or $50 a month back. If you're a low income senior and someone's offering you $1,200 a year of extra income, it may be the most valuable supplemental benefit, period, full stop. And frankly,
they should have to screen people for MSPs before they enroll people in any plan that gives you your Part B premium back. The plan should be required to screen you for an MSP before they enroll you in that plan. That's my 2 cents on rebate plans. And I think this actually goes to one of the questions, or ties to the question, which is what about veterans affinity plans, or what about plans that have affinities? And this also touches on the question, the point I raised about lookalikes, or plans that are targeting either on purpose or inadvertently dual eligibles. The specific plans need to be very aware of what else exists in the marketplace that people may confuse them for, and what people might believe about the relationship between that plan and those other things. And I think
the one thing I'll say, Casey, is I really think there needs to be like fundamental reform on the federal government's interface between beneficiaries, because the same people who are accessing Social Security benefits are accessing Medicare benefits, and they're accessing housing benefits, and they're interacting with 4 different agencies who don't actually talk to each other. And frankly, there should be decision support and AI, AI enrollment assistance that actually helps guide people based on what they're actually eligible for from a common database that actually cross-checks their and frankly bumps them to the thing that they most benefit from. And it's embarrassing, again, like I think our regulatory oversight over these programs has not kept pace with the actual change in capabilities in our industry. And I think that's where we need to take things. That's the innovation that needs to happen, like very urgently. And that's not a democratic issue or a Republican issue. That's just like good execution of a program issue. And frankly, it just makes my blood boil that we don't actually think more about that kind of stuff.
Yeah.
No, the failure of
and
no wrong door is something I could talk about for a lot of days. I think you're absolutely right.
I feel like this conversation could continue and continue. There's so much to talk about. We have 4 more minutes left, so I just wanted to maybe give you all a moment to just say some concluding remarks about your thoughts about affinity plans. And there is one question in the chat around how you're thinking about the CMS Health Equity Index that's going to be included in the star ratings in 2027. So if either of you in your final comments would like to mention something briefly about that, then that'd be great. Do you want to start where did we start, in reverse order? Casey, did you want to say your final comments and then pass it to Andy and then Sachin?
Sure. I don't think I have I don't have anything specific on the health equity index, except that I think that the intersection with and understanding about how plans interface with Medicaid will continue to be extremely important, whether they are DSNPs or not. Dually eligible people are more likely to have worse health outcomes and also more likely to be otherwise disadvantaged. And so I think that is a real area for improvement across the board.
Yeah, and thanks, Casey. And then from where I sit, for Clever Care, I think, like Sachin said, we're in like the second inning of these types of tailored plans. Clever Care, when we think about a smaller organization carving out a niche founded by Asian Americans, built from the ground up to serve an underserved community, we think there's a place for an organization like Clever Care to do a better job than maybe a larger national plan can do for these communities. And I think we're going to learn as we go. It's not perfect, and there are going to be unintended consequences, and there are going to be some shifts here and there. But we do feel like an organization that has in its DNA the ability to serve and provide benefits for these members in a way that's different. We think there's a place for plans like that, and I think more consumer choice is a good thing. And members are picking plans based on their chronic disease. They're picking plans based on social risk factors. We think they can be picking plans based on their ethnicity or other social or other needs. And we think there's a place for that. I think it's a good thing for consumers.
Great. Sachin?
Yeah, I mean, I just go back to the original intent of the program, that Harry Truman first introduced and that Lyndon Johnson, kind of wrote into law. Harry Truman was the first beneficiary. The whole point of this program was to provide income security for older adults. It was supposed to provide income security as well as full coverage to older adults. And what has happened since then is that traditional Medicare has not kept pace, that it has pushed tons of out-of-pocket costs. After working your entire life and paying Social Security and Medicare taxes your entire life, you have the privilege of paying up to $1,000 in premiums for a family of two when you're an older adult with an average income of $51,250. So that's the state of traditional Medicare. So Medicare Advantage is trying to solve that problem. And I think one of the greatest opportunities for innovation is like further tailoring benefits to specific populations. And I think, there's a lot of skew, there's a lot of challenges here, but the opportunity is really exciting. And I think it's something that, those who are skeptical about MA should lean a little bit farther into. They should meet beneficiaries. They should talk to people in communities. They should understand how these benefits are actually being used. And then I think we should be thinking about how do we actually improve the regulatory oversight to ensure that the program is doing what we think it's doing. So
I will say that
I thought I had the last word, Casey.
Yeah, we're at the top of the hour. So
the traditional Medicare slander go unanswered, because I think that there's two stories to the graph that say that that MA is disproportionately enrolling people with more limited incomes. One of the parts of the story is that it serves their needs particularly well. The other part of the story is that, and I think that in terms of talking to beneficiaries, you have to admit that this is true. If you are talking to someone who does not have financial limitations, they're choosing traditional Medicare and a Medigap every single time.
Yeah.
I have never talked to a
I'm
beneficiary
sorry
who said,
Casey, I'm sorry to interrupt, but just for respect for the audience, we want to stop at 1 o'clock. And
yeah, of course.
I just want to thank all the panelists and Andrew for terrific moderating and Mark for his comments at the beginning. And thank you to our audience for a wonderful hour together.
Thank you. Appreciate the time.
Thank you so much.
Thank you.
Thanks.